Let me tell you something about stroke in posterior circulation. We start with Basilaris thrombosis. You do have fluctuating optomotoric disorders, tetraparesis or hemiparesis, dysarthria, and fluctuating consciousness. The most common prodromal symptoms are vertigo, nausea and headache within the first 2 weeks before the stroke. You have embolism and atherosclerosis as a cause. The patient may be comatose or may have disorders of consciousness. Eye symptoms, I call them simply eye symptoms. You do have various optomotoric symptoms. You have a pathological motor response to external stimuli with extensor posturing, for example, and you may find bilateral Babinski. The syndrome of the middle basilaris artery, you do find initial hemiparesis because rami ad pontem on one side may cause hemiparesis on the other, but then bilateral rami ad pontem thrombosis will cause tetraparesis due to bilateral pontine infarction. You again have eye symptoms with nystagm, and a locked-in syndrome, which is very rare initially, may follow later on. Caudal vertebral basilar thrombosis, you may find bilateral cranial nerves, you may see ataxy, again hemiotetraparesis, and initially no disorder of consciousness. It's very often atherosclerotic. Tip of basilaris thrombosis, again you see optomotoric troubles, you may have tetraparesis and early disorders of consciousness, and if the thalamus is involved bilaterally, you do see hypersomnia in paramedian diencephalic syndrome. The tip of basilaris thrombosis very often is embolic of origin. So that's my picture for the hypersomnia in the diencephalic syndrome with bilateral thalamus infarction, where patients have abnormal sleeping and abnormal hypersomnia. Basilaris thrombosis may occur suddenly, but very often you see progression of symptoms, progression of brain stem signs, and fluctuating symptoms. Let's go to the cerebellum. So that's the cerebellum from the side here. Cerebellum, brainstem, pontine region. If you have a pica infarct, a cerebellar inferior posterior infarction, which would be located here, you do have hemiataxy, dysmetry on the affected side, and nystagm. Sometimes, if the dorsolateral medulla oblongata is involved as well, you have brainstem symptoms with Horner syndrome, dysphagia, and hoarseness. So the patient actually tells you, I have the feeling I'm walking like being drunk, and I feel dizziness and vertigo. Then you let the patient walk, and you will see he may fall towards the side of the affected cerebellum. If this cerebellar infarction becomes space occupying, it will compress the brainstem toward the clevus. Patients become unconscious. They also have double vision, pupillary disturbances. Sometimes you may see hiccup and vomiting, and they then develop tetraparesis and bilateral positive Babinski sign. Space occupying occurs within 1 to 4 days after initial stroke, due to the compression of the brainstem, but also due to disturbed liquor passage. You need a quick therapy because mortality is very high without surgery, but prognosis can still be quite good even if the patient is unconscious at the time of surgery start. Thanks for your attention.